Expansion of medical needs.
Changes in Korean medicine have been closely related to changes in Korean society, particularly in the political system. In 1972, Park Chung-hee amended the constitution to allow him to stay in power for life and to give the president the power to dissolve the National Assembly. This was a consolidation of the dictatorial system and led to a strong social backlash. In an attempt to calm unrest, a number of healthcare and welfare benefits were introduced during this period of major political upheaval. One of the most notable was the introduction of the National Medical Insurance System, which we will return to later. Another was the elimination of villages without doctors, which had been an endemic problem in the Korean medical system since shortly after liberation. Although there had been an expansion of health centers since the 1950s, there were still insufficient staff to keep them functioning properly. To solve this problem, the government sought to mobilize medical personnel. And this mobilization system has since become a source of deep-rooted conflict between the government and the medical profession. After liberation, the introduction of the concept of specialization and a private sector-oriented healthcare delivery system in the United States led to a significant increase in the number of hospitals and beds. From 9,951 in 1960 to 10,613 in 1964 to 16,538 in 1970. In particular, in line with the American model of healthcare, in which the state is responsible for public health and the private sector for treatment, financial support for public hospitals decreased, and the role of private hospitals increased. By 1966, the number of beds in private hospitals has begun to exceed the number of beds in public hospitals. This had a vicious effect on the people's confidence in public hospitals, leading to further management difficulties. At the same time, the decrease in government financial support for hospital meant that patients had to pay more for medical treatment, which led to lower utilization of public hospitals. In the 1960s, the national average bed utilization rate was no more than 50%. National university hospitals, which had played a major role in training doctors, responded to this situation by lowering their labor costs. The special accounting law for national university teaching hospitals, which came into effect on January 1, 1966, guaranteed national university teaching hospitals autonomously use of their excessive revenues, such as medical practice income. Although its purpose was to revitalize university teaching hospitals in practice, it worked by reducing government subsidies. The essence of the law was that budgets used for staff wages and expansion of hospital facilities were classified as general accounts and subsidized by the national treasury, while other personnel costs and hospital accommodation costs were covered by the hospital's own revenues from special accounts. This gave medical teaching hospitals the autonomy to use their budgets and increased hospital revenues, but it did not have much effect in the face of the low bed utilization. Hence, as in the US, the pressure to expand externally and to increase hospital revenue led hospitals in Korea to treat interns and residents as labor rather than as trainees.
Graduate medical education.
Immediately after liberation, clinical training, internship, and residencies were not institutionalized in Korean medical education. Some mission hospitals and institutions operated independent internship program, but there was no state intervention. The US military government that ruled Korea after liberation believed that this was a major factor in lowering the quality of medical care. As in Japan, the US military government pushed for reform to medical education in Korea that would strengthen clinical practice. As a result, when the 1951 National Health Care Act was drafted, a clause was inserted that read, Article 17, a medical practitioner shall not be granted a license unless he or she has completed at least 1 year of clinical practice. In Japan, this clause was added to the law, which required a 1-year internship before a doctor's license could be issued. In other words, it was a compulsory clinical training law. However, this provision was removed from the final draft in Korea due to the fact that medical students gain a certain level of clinical experience in their 3rd and 4th years of medical school. And the practical problem that there were no sufficiently large hospitals to accommodate the number of graduates that were produced every year as interns. Another major problem was that there was a severe shortage of medical personnel to add another year of training. The need for the institutionalization of clinical training was again discussed in connection with the rise of specialists. The Medical Service Act of 1951 allowed those who had completed at least 2 years of training and 6 years of practicing medicine with a specialized subject to be granted a certified specialist after a document review. As a result, 21.1% of all registered doctors were certified as a specialist from 1952 to 1959, spreading the preference for specialists not only among doctors but also among the general public. With the growth of the private healthcare market, specialization became a matter of profit for doctors. Despite this growing demand for specialists, the training system varied greatly from hospital to hospital, and the qualification requirements were not uniform. In 1951, the specialist policy was launched, requiring 5 years of training at a general hospital as a prerequisite for qualification, but did not stipulate any guidelines for training requirements or curriculum. In 1957, a decision by the Review Committee for Specialization made it impossible to obtain permission to specialize without training at a general hospital. This led to the Ministry of Health designating 60 training hospitals, and a system was introduced to designate training hospitals based on regular surveys. The process to become a specialist was gradually institutionalized. As the training process for specialists became increasingly institutionalized, attempts were made to systemize the training of interns and residents, which had previously been managed autonomously by hospitals. One of the major influences on postgraduate medical education at the time was the Minnesota project that we discussed earlier. This project to reconstruct higher education through the US government from 1954 to 1961 played a key role in the transition from the Japanese style of medical education to the American style one. Along with this, there was a consensus that post-graduation training such as internship and residencies needed to be standardized. As a result, internships began to be formally recruited in 1958 and were managed on a national level.
Americanization and brain drain.
Let's take a look at the brain drain since the Vietnam War. In 1965, there were only 300 immigrant doctors from Asia in the US, but by 1972, the number exceeded 5,000. By 1975, doctors who had graduated from medical schools abroad and moved to the US accounted for 1/3 of all trainees and 1/5 of all doctors. Considering the fact that South Korea, where half of the country was doctorless, is providing 20 doctors to fill just one hospital in the eastern part of the United States, the brain drain from South Korea to the US became a serious problem even in the United States. It even led to the congressional hearing in the US. This was because even though the US had provided huge amounts of aid such as $10 million for Minnesota project, the outflow of trained specialists to the US would eventually reduce the effectiveness of the aid. Estimates suggest that the amount of aid that could be saved by stopping the outflow of doctors from Korea to US could be as much as $1 billion a year, or equivalent to building 2.8 medical schools. During the time to renew physician license in 1974, there were 15,118 registered physicians in Korea, and 2,093 Korean medical school graduates practicing in the US. This meant that approximately 10 to 15% of the physicians produced up to that moment had left the country, and the majority of them were granted permanent residency between 1970 and 1972, when the US was actively recruiting overseas physicians in the aftermath of the Vietnam War. In 1971, the number of newly green-carded Korean doctors in the US reached as high as 810. With the unresolved Korean doctor shortage, the Korean government had to take action against the brain drain. In August 1969, the Korean Ministry of Health announced a restriction on overseas travel for doctors, requiring them to complete a minimum of 1 year of work in a doctorless village before they could travel abroad. From the outset, the travel restrictions were met with strong opposition from the medical profession, particularly from trainees who regarded the United States as their only way out. The growing conflict between the medical profession and the government, which had been escalating since the late 1960s and threatened the monopolistic position of doctors in the healthcare system that had been guaranteed by the state, was also one of the reasons for the escalating wave of trainees. In 1965, in an effort to expand the organization of health centers, the government proposed an amendment to the Medical Service Act to allow non-physicians health personnel to be appointed as directors of health centers, including osteopath and acupuncturist. The recognition of the legal status of non-physician health personnel and the relaxation of the qualification requirements for health center directors were perceived as expanding the pool of potential competitors and reducing the social status of doctors. Doctors even attempted the first collective action to stage a protest demonstration in front of the National Assembly. In 1970, the Ministry of Health announced its intention to equalize the disparity between the number of doctors in public and private hospitals. And this was interpreted as direct government interference in the management of not only public but also private hospitals, sparking a backlash from the medical profession. Because the state-guaranteed position of doctors got gradually narrowed and competition for clinics as well as hospitals became increasingly fierce, trainees became skeptical about their future. Against this backdrop, the restrictions on overseas travel provided a crucial trigger for the wave of trainees. In 1971, trainees in major hospitals across the country went on strike simultaneously. There had been sporadic strikes by nurses and interns in the 1960s, demanding higher wages and better working conditions. But a nationwide strike involving trainees from multiple hospitals was the first. At the time, interns were paid very low wages, which were only enough for 5 meals. But still, they were expected to be in the hospital for 24 hours a day to do most of basic tasks. A look at the perception of the trainees at the time reveals that as much as they were dissatisfied with their overall treatments, accommodation, food, and salary, they were also not satisfied with the quality of their education and the training system itself, and distrustful of the established medical profession. In a survey conducted with 102 interns in 1971, only 4 felt that their training was going well. And interns and residents called for a removal of restrictions on international travel, better training, and more.